we are very excited for today's program because we're having one of the most famous voices in the movement disorders world with us today, Dr. Joe Jankovic. We're going to be talking about skin conditions in Parkinson's and atypical Parkinson's and things that might even happen with treatments for Parkinson's. And so I know I'm very interested in this topic. I know we've heard about some of them. People are aware of melanoma issues maybe, but honestly, I am excited to learn some new things that I didn't even realize were a part of the experience with Parkinson's. So I'm going to introduce our speaker. If you've not heard of Dr. Joe Jankovic before, he is a professor of neurology, distinguished chair in movement disorders, movement disorder specialist expert, who is the founder and director of the Parkinson's Disease Center and Movement Disorders Clinic, Department of Neurology at Baylor College of Medicine in Houston, Texas. And I'm very grateful that he was willing to be a part of our program today. So Dr. Jankovic, I am thankful you're here, and I'm going to hand this over to you.
Okay, I hope you can all see my slide. And thank you so much for the generous introduction. I'm delighted to spend some time with you this afternoon. I'm currently in Houston, Texas. I'm a professor of neurology at Baylor College of Medicine, as was pointed out in my introduction. I'm also the third president of the International Parkinson Disease and Movement Disorder Society. So I've been involved with Parkinson for more than 50 years. So the topic that I was asked to discuss today is something that I've been interested in a long time, is the role of skin in Parkinson's disease and how Parkinson's disease can affect skin. We think of Parkinson's disease as a motor disorder manifested mainly by tremors, slowness of movement, rigidity and shuffling gait and loss of balance, these kind of motor symptoms. But we don't often recognize how important non-motor symptoms such as behavioral and cognitive changes, but also changes that affect other organs besides the brain. So skin is one of the organs that is often affected in Parkinson's disease. And I just want to share with you some of the recent findings about the relationship between Parkinson's disease and skin. So let's see. So about a year ago, I was interviewed by Brain and Life magazine about this topic because we previously published a paper on the relationship between Parkinson's disease and skin. And I pointed out in that interview that the skin can be a window into the diagnosis of Parkinson's disease. And that's what I would like to emphasize during this presentation. So the article that I was interviewed about was published actually a few years ago now, together with my fellows, Dr. Neiman and Dr. Vilnitzer. And in that article, we reviewed what is known about skin in Parkinson's disease, and we decided to divide the skin conditions associated with Parkinson's disease into two major categories. Iatrogenic, and iatrogenic means caused by some kind of a treatment, or non-iatrogenic, meaning it's not due to any particular treatment. So that is the approach that I'm going to take in this review. So among the sort of a spontaneous non-iatrogenic conditions that can affect the skin in patients with Parkinson's disease, the most important one to highlight is melanoma. Melanoma, as you know, is a malignant condition of the skin that can be fatal, and it is much more increased in terms of frequency and severity in patients with Parkinson's disease. I'll spend just a few slides talking about melanoma. I'll say a few words about seborrheic dermatitis, which is probably the second most common skin condition. Well, in some ways, it's more common in melanoma, but it's probably less important, even though it's more frequent, which is defined as a sharply demarcated red lesions that usually involve the periorbital, the eye area, perinasal area around the nose and scalp. We'll say a few words about sweating disorders, especially in relationship to another condition related to Parkinson's disease, namely multiple system atrophy, which is a Parkinsonian condition that often affects the autonomic nervous system that regulates body temperature and regulates blood pressure and bladder and sexual dysfunction. Bullous pemphigoid, I'm not going to spend much time on that. It's a relatively rare condition that is often autoimmune, but for some reason tends to be more frequently represented in people with Parkinson's disease. Rosacea is another condition, a skin condition that can affect particularly the face, but can also affect the abdomen and trunk. I may not have time to talk about drooling or sialorrhea, which can affect the skin around the mouth, so that individuals with Parkinson's disease often experience drooling, especially at night or even during daytime, which can cause some irritation of the skin around the mouth. And then rarely, some people with Parkinson have a neuropathy that may affect the skin to some degree, but that's quite rare. Among the iatrogenic skin conditions, again, conditions due to treatment, we'll talk a little bit about levodopa carbidopa intestinal gel, subcutaneous infusions, amantadine, dopamine agonists, and deep brain stimulation. Probably the most important relationship between skin and Parkinson's disease is that, as I pointed out earlier, skin can be a window to the diagnosis of Parkinson's disease. And I'll spend probably half of the time talking about the importance of skin as a diagnostic biomarker. So I first became interested in the relationship between Parkinson's disease and melanoma at least 20 years ago, when we published this first article in 2011, trying to highlight the increased risk of melanoma in patients with Parkinson's disease. And then we discussed a variety of possible mechanisms that may lead to increased risk of melanoma in patients with Parkinson's disease. Here are some examples of melanoma, which starts, of course, in the skin, but it may start in the retina, some other parts of the body, and often, if not detected early, can metastasize and can potentially be fatal. So a number of studies have shown that people with Parkinson have at least 2 or 3 times higher risk of developing melanoma compared to the general population. The mechanism of this association is really not well understood. It's sort of interesting that in Parkinson's disease, as you know, that there is a decreased pigmentation in the part of the brain called the substantia nigra, which contains the dopamine-producing neurons in the brain. So the melanin, which is in this part of the brain, is identical to the melanin that is also present in the skin. So there's a relationship between Parkinson's disease and this pigment called melanin. I will talk a little bit about alpha-synuclein. I think all of you are familiar with alpha-synuclein, which is a protein that has been found to accumulate in the brains of patients with Parkinson's disease, and it also accumulates in other parts of the body, including the intestines and the skin. And there's some suggestion that perhaps the alpha-synuclein in the skin may drive the replication of the skin and result in the development of the cancer of melanoma. There's some suggestion that genetic factors may contribute to the relationship between Parkinson's disease and melanoma, as noted that melanoma is much more common in people with Parkinson's disease who have family history of Parkinson's disease or melanoma. Initially, there was some speculation that L-DOPA, which converts to dopamine and eventually to melatonin, could potentially increase the risk of melanoma in patients with Parkinson's disease. But many studies have been conducted to address this issue. And we currently believe that there is no evidence that levodopa increases the risk of melanoma in patients with Parkinson's disease. Nevertheless, because of the relationship between Parkinson's disease and melanoma, people with Parkinson's disease should undergo regular skin checks to detect melanoma. Now, I'm not going to talk about the treatment melanoma, but there are some exciting new developments in the treatment of melanoma using PD-1 inhibitors. These are drugs that attack part of the immune system, which then inhibits the growth of the tumor cell. Just to show you how current I am, this is a headline this morning on CNN about Jerry Jones, who, as you know, is the owner of Cowboys, who revealed that he had decades long of the treatment for stage 4 melanoma and is now considered cured as a result of these new drugs, PD-1 inhibitors. So here's an example of a patient with seborrheic dermatitis showing this flaky skin around the eyebrows. It can also be around the nose, ears, and scalp. This is probably the most common skin manifestation of Parkinson's disease and may present before motor symptoms of Parkinson. Now we have a number of patients who started with seborrheic dermatitis before they noticed tremor or other Parkinsonian features. So it potentially could be a prodromal feature of Parkinson's disease. So we talked about melanoma, seborrheic dermatitis. I'll say a few words about hyperhidrosis later on. And I want to switch to the iatrogenic forms of skin abnormalities in Parkinson's disease. You know, it's skin problems that are due to treatment. So I think most of you are familiar with duopa. In some countries, it's called duodopa, where we infuse levodopa gel directly into the stomach or small intestine in patients with Parkinson's disease in order to smooth out the motor fluctuations. And from this early study published more than 10 years ago, you can see that the complication of the device was by far the most common complication and refers really to some of the skin abnormalities around the site where the tube enters the stomach. So there are often associated changes because of inflammation and irritation. So this is the levodopa gel. This is our first patient who was treated with this dopa. So in addition to intestinal or stomach administration of levodopa, we now have the ability to administer levodopa under the skin subcutaneously using fos-carbidopa or fos-levodopa, also referred to as Vialev. So this is a continuous levodopa infusion, also referred to as produodopa, that is designed to smooth out the motor fluctuations in people with Parkinson's disease. And you can see here how this infusion is administered via pump. This is our first patient who underwent this subcutaneous infusion when it was still experimental. And you can see this inflammation around the site of infusion. And here are other examples of nodules and inflammatory changes that occur at the site of infusion, and therefore the infusion site has to be changed. This is from a study was published just this year, showing what actually happens in the skin when individuals receive this continuous subcutaneous levodopa infusion, showing these inflammatory changes in the skin that fortunately subside when we change the site of the infusion. Besides levodopa, we can now infuse apomorphine, which is a drug referred to as dopamine agonist that stimulates the dopamine receptors directly. So it's not a precursor of dopamine, it's actually stimulates the dopamine receptors in the brain. And that drug, apomorphine, has been previously available as an injectable forms, as a rescue therapy. So people who are in an off state, they can inject themselves with the apomorphine, and within 10, 15 minutes, they turn on. That improvement may last an hour or two, and it enables them to function at least for a period of time and rescues them from their off period. Just this year, the FDA approved a continuous apomorphine infusion that is administered again subcutaneously under the skin, similar to what I just mentioned about levodopa. But unfortunately, many patients again experience the infusion site nodules and redness and inflammation. So this is from the study that was published a few years ago and led to the FDA approval. And again, you can see that skin nodules and infusion site problems occur in almost half of all the patients who are treated with this infusion. Another common skin abnormality seen in the setting of Parkinson's disease is this reddish, bluish mottling of the skin called livedo reticularis, seen in patients treated with amantadine or gocovri. It's usually not a disabling condition, and we don't have to necessarily discontinue the drug because of the occurrence of the livedo reticularis, but it is sometimes embarrassing to the patients, and so on occasions we have to reduce or stop the medication to stop that side effect. This is an example of a patient who has the cold hand symptom in a setting of multiple system atrophy, which is a Parkinson disorder that affects the autonomic system. They can have cold feet, so the skin can be affected in this condition called multiple system atrophy. This is from a study from Mayo Clinic published some time ago, where they showed that people with multiple system atrophy and autonomic dysfunction may have normal sweating at the beginning of their disease, but as the disease progresses, in this case only a year later, you can see that using this thermoregulatory sweat test, there's basically absence of sweating because of the autonomic involvement of the skin. So again, anhidrosis or lack of sweating is a common manifestation of multiple system atrophy, but occasionally can be also seen in the setting of Parkinson's disease. Another iatrogenic skin condition affects patients who are undergoing deep brain stimulation or DBS, where, as you know, the electrode is placed into the part of the brain called basal ganglia, which is involved in Parkinson's disease. And this is attached to this pulse generator that produces high frequency stimulus to suppress the symptoms of Parkinson. But in this site where there is this connector, there's often some irritation of the skin, as noted in one of our patients, showing the skin erosion in the placement of the DBS. Now, I mentioned alpha-synuclein, which is an extremely important protein that accumulates in the brains of patients with Parkinson's disease and causes some of the damage, including degeneration of the dopamine-producing neurons in the substantia nigra, in the part of the brain that contains the melanin and also the dopamine-producing neurons. This is from a review article that I was invited to submit at a 100-year anniversary of this journal called Journal of Neurology, Neurosurgery and Psychiatry, where we talk about alpha-synuclein and its role in causing Parkinson's disease. Now, alpha-synuclein not only causes neurodegeneration in patients with Parkinson's disease, but also other conditions like dementia with Lewy bodies, and I just mentioned multiple system atrophy. But there are other Parkinson conditions that do not necessarily include alpha-synuclein, but these three disorders, Parkinson's disease, dementia with Lewy bodies, and multiple system atrophy, are clearly associated with alpha-synuclein pathology and cause neural damage. So because of alpha-synuclein's role in Parkinson's disease and these other Parkinsonian disorders, investigators have tried to see if they can detect alpha-synuclein in spinal fluid, in the saliva, in the blood, but also in various tissues, including the retina, salivary glands, intestine, and then, of course, skin. By detecting alpha-synuclein in the skin, we can now support the diagnosis of Parkinson's disease in a number of individuals. And this is again from a training that all of us underwent in our center at Baylor, so that we learned how to do the punch biopsy for the skin diagnosis. And you can see that in Parkinson's disease, we sample three areas in the neck, under the back part of your knee and the ankle, and we biopsy these areas looking for alpha-synuclein. And in Parkinson's disease, the alpha-synuclein is present in almost all cases of Parkinson's disease, particularly in the upper part, including neck. In MSA, the multiple system atrophy is diffusely present throughout the skin, and so is the case with dementia with Lewy bodies. So I'm not going to bore you with the details about alpha-synuclein, but this is how alpha-synuclein accumulates in the nerve tissue of the skin and also in the brain, causing these inclusions that we call Lewy body inclusions. You probably have heard about those. It's a pathological hallmark of Parkinson's disease in the brain. We don't necessarily see the Lewy bodies in the skin, but we certainly can detect Lewy bodies by a special kind of staining. This is taken from an important study published about 5 years ago, where the investigators found that alpha-synuclein can be detected in large portion of patients with Parkinson's disease, also in patients with MSA and Lewy bodies, but not in patients with Alzheimer's disease, progressive supranuclear palsy, cortical basal degeneration, or normal controls. So this skin test looking for alpha-synuclein can clearly differentiate diseases that are due to alpha-synuclein pathology, such as Parkinson's disease, compared to other neurodegenerative disease like Alzheimer's disease, PSP, CBD, or normal controls. So it has a very high diagnostic accuracy. And as I noted, almost all patients with Parkinson's disease have this alpha-synuclein in the skin, just like they have it also in the spinal fluid. But obviously, the skin is more readily accessible, and we now use the skin biopsy instead of looking at alpha-synuclein in the spinal fluid as a potential diagnostic test to confirm the diagnosis of Parkinson's disease. We work with a company called PMD Life Sciences, and this is an example of a report that we obtained about few weeks or months after the biopsy, showing, for example, that there is abnormal accumulation of alpha-synuclein in the skin, and there may be some other changes in the nerve fibers in the skin. Now, we've been very interested in the relationship between a condition called essential tremor in Parkinson. Essential tremor is much more common than Parkinson. It's a cause of tremor. It's one of the most common causes of tremor. And I and other investigators believe that a subset of patients with essential tremor may be at an increased risk for developing Parkinson's disease. So we did a study that is still ongoing to see whether people with essential tremor without any clinical evidence of Parkinson's disease have evidence of alpha-synuclein in the skin. And you can see that, at least in this study, 60 to 70% of patients with essential tremor had abnormality in their skin in terms of the presence of alpha-synuclein, suggesting that a subset of patients with essential tremor might be at an increased risk for developing Parkinson's disease. And this is from a paper we just published where we suggested that essential tremor may be a prodromal feature of Parkinson's disease occurring many years or even decades before other features of Parkinson's disease, looking at a variety of biomarkers, including skin. I just put in this slide in this morning when I was preparing for this talk to illustrate another example how skin can be affected in Parkinson's. This is a woman with a REM behavioral disorder acting out her dreams during sleep, as a result of which she fell out of bed and injured her right orbit, causing this hematoma. Another way that skin can be can play a role in Parkinson's disease is as a potential treatment. So this is from a paper that we published just a couple of years ago in response to an article about an individual who used his own skin to produce these stem cells, induced pluripotent stem cells, which were then implanted into the brain and presumably resulted in some improvement in his Parkinson. There are a lot of questions about stem cells. I don't want to go into the stem cells topic, but you will be hearing more and more about what's called autologous stem cells, meaning stem cells from the individual's his own body, his own skins, that can be converted into stem cells and then implanted in the brain. So just to conclude, I want to summarize some of the key features. Skin-related manifestations of Parkinson's disease are common and well documented in the literature. Conditions such as seborrheic dermatitis or sweating dysfunction may precede the diagnosis of Parkinson's disease and can serve as potential diagnostic clue in the early presentation of Parkinson. Melanoma is seen more commonly in Parkinson's disease than in general population. Iatrogenic skin conditions such as rashes from therapies or skin changes from, for example, amantadine, subcutaneous nodules from infusion therapies such as levodopa or apomorphine are important to recognize. And then the skin irritation in patients with undergoing DBS at the site of the implantation. So the skin plays an important role in Parkinson therapy, and also might potentially be a source of patient-derived stem cells that can be used as a disease-modifying therapy. You probably heard about this study of dogs that can diagnose Parkinson's disease, and eventually probably will replace neurologists in making a diagnosis of Parkinson's disease. This is from a study which just published where they trained Bumper and Peanut, two dogs, to see if they can smell swabs from people with Parkinson and differentiate the odor from people with Parkinson's disease from normal controls. And this study reported very high specificity in terms of differentiating between people with Parkinson's disease and normal controls just by smelling the swabs from the skin. So I'm going to stop here, and I'll be happy to address any questions you might have.
Thank you. And how sweet, Bumper and Peanut. Very cute. So I actually have a question related to Bumper and Peanut's abilities, and many people may have heard of the lady Joy Milne, who supposedly could smell Parkinson's. And in fact, I think she even did a small study about staging people uh, based on their smell. Can you explain what exactly the dogs are smelling? Is it sebum? What is it on their skin that they're smelling, or is it from the skin?
I wish I knew. They don't talk to us about what they smell, but I suspect that they can somehow differentiate between the smell from the skin of people with Parkinson's disease and normal controls. What exactly they are smelling is really not known, but it's likely that the sebum, the skin secretion from individuals with Parkinson's disease is different in terms of the odor than controls. Now, as you mentioned, there are rare individuals who can also differentiate it, but that has to be confirmed. This study with the two dogs was a well-designed study, and probably has some credibility, but I'm not sure about the other reports of individuals being able to differentiate between Parkinson's disease and normal controls just by smelling them.
Yes. Well, that's why I sort of referred to the dogs more, but it's very curious. So questions around the seborrheic dermatitis. Is urea lotion a good choice for treatment? 10% says urea lotion. I don't know if that's.
So I don't necessarily want to go into the treatment. It's not something that I'm usually involved with. If I see patients with dermatitis in Parkinson's disease, I just refer them to dermatologists, and they apply a variety of treatments, often some lotions, but also topical steroids, which reduce the inflammation. But that's something that I would refer to the dermatologist for specific treatments.
Fantastic. There's also a question, can Parkinson's cause oily facial skin and acne and frequent breakouts? Is that something you've seen?
So yeah, Parkinson's disease certainly can cause oily skin. Whether it actually causes acne or not, I don't think that has been well demonstrated. But yes, Parkinson people often have oily skin, especially on their forehead and their face, but also other parts of the body.
So, in regards to melanoma, I know that is obviously a concern for people. Is there any difference between those who have darker skin versus lighter skin in terms of risk?
I don't think that has been demonstrated. Obviously, people have looked at that, but so far, I don't know of any study that have demonstrated any difference between individuals with darker skin versus lighter skin.
And I know you mentioned excessive sweating. So I know that that is probably a challenge for people. I wanted to know if you could maybe mention some watch outs for somebody who's actually dealing with excessive sweating in terms of risk factors, maybe dehydration or anything like that.
So excessive sweating certainly can be a symptom of Parkinson's disease. We often refer to a syndrome called drenching sweats of Parkinson. These are individuals who, especially at night, have tremendous sweating. They wet their bed because of the sweating. It often interferes with their sleep. Um, uh, why that happens, no one knows, but obviously these individuals have some hyperactivity of the autonomic nervous system, which causes the excessive production of sweat. Um, it's a condition that's not easy to treat, but sometimes anticholinergic drugs, drugs like trihexyphenidyl or Artane, which used to be used quite frequently in treatment of tremor associated with Parkinson's disease. That kind of drug that blocks the cholinergic system can be useful in controlling the excessive sweating. And then there are patients who are sort of the opposite, who actually have anhidrosis, as I mentioned, with respect to multiple system atrophy, where they just cannot sweat. So, these individuals obviously need to be hydrated and use some moisturizing lotions to help the skin to remain, healthy.
Thank you. So we had a question about whether medications can cause spots on the skin. I know you showed some things. Are spots on the skin something to be checked by a doctor or dermatologist
So there
related
are
to
many
meds?
reasons why people have these dark spots or hyperpigmented areas. That is often seen in normal individuals. They may not be more commonly seen in Parkinson's disease, but anytime somebody discovers a hyperpigmented spot, particularly if it's raised slightly, they should definitely seek a consultation with a dermatologist to make sure that it's not the beginning of melanoma.
Okay, I have a melanoma question, and it's tricky, sort of, because I recognize that you're not a dermatologist, but I'm assuming that this person asking has Parkinson's. So this person is saying their mother had melanoma twice. They did not have Parkinson's. Does the person with Parkinson's have a greater chance of getting melanoma if they had a parent that had a history of melanoma, even without Parkinson's?
Yeah, the answer to that is yes. There have been a number of epidemiological studies to show that people with melanoma have a higher risk for Parkinson's disease, and family members of people with melanoma have an increased risk of Parkinson's disease. So there is a relationship, genetic relationship, between melanoma and Parkinson's disease.
This may seem sort of a silly question, but how do you balance reducing UV ray exposure, obviously, which increases risk of melanoma, I would assume, that's what I've heard, versus not getting enough sunlight and vitamin D? I know you can take supplementation. Is that enough?
Um, yeah, that's a frequently asked question, and there was actually a recent meta-analysis that looked at vitamin D, for example, whether vitamin D improves motor function of patients with Parkinson's disease. And the answer to that is probably not. And I don't necessarily want to encourage people to start taking vitamin D because there's really no evidence that vitamin D either slows down the progression of disease or controls the Parkinson symptoms. But obviously, people with Parkinson should be aware of the increased risk of melanoma and take precautions with respect to exposure to UV light, use the proper, precautions. And again, I cannot emphasize enough how important it is for Parkinson patients to have periodic dermatologic evaluations, specifically looking for melanoma.
So in regards to the skin biopsies, the SIN1 test, are there any differences in alpha-synuclein for those who have genetic forms of Parkinson's versus idiopathic Parkinson's?
That's a very important question. So there are certain genetic forms of Parkinson's disease, like, for example, LRRK2 mutation or GPA mutation. These are specific genetic forms of Parkinson's disease that may or may not involve alpha-synuclein. So there is some evidence to suggest that people who have these genetic mutations like LRRK2 or GPA, that they probably do not necessarily have increased concentration of alpha-synuclein in the skin. So it's more commonly seen in the so-called idiopathic Parkinson's disease than the genetic forms of Parkinson's disease.
You said it's very, very rare, and you mentioned it, but could you explain what bullous pemphigoid is, if I'm saying it right?
Yeah, bullous pemphigoid. It's a condition that causes sort of like blisters, particularly in the trunk or abdomen. It may not necessarily be associated with Parkinson's disease. It's a relatively common condition that is thought to be autoimmune, but for some reason it might be seen more frequently in people with Parkinson's disease.
I don't know if there's any other questions that our audience has. You have been very thorough in covering all of these things, so you might have answered everybody's questions as you were explaining them. This has been fascinating. I know I learned a lot today, and it's obviously, they say the skin being the largest organ we have tells us a lot. So it sounds like you agree with that, and you've covered quite a bit.
Right. It can be a window into the brain, and more specifically into Parkinson's disease.
Fantastic. Well, I want to thank you so much, Dr. Jankovic, for taking the time. I know you have to get back to clinic, but we appreciate you giving us such a wonderful presentation today. There's something that we do at PMD Alliance to show our gratitude, because we can't really clap to thank you for you to hear it because everyone is muted. But I would invite you, everyone, if you can turn on your cameras and give him the wave of gratitude to thank him for this. So I appreciate it. And
Thank
this will be,
you.
this is recorded, so this will be available on our website in a day or so. So thank you, everyone, for joining us. Thank you, Dr. Jankovic.
Thank you, and send me the link, okay?
We'll do it. Thank you. Take care.
It was a pleasure. Bye-bye.
Bye.